medialis means it's on the medial side, vastus lateralis on the lateral side, and rectus femoris. Femoris means obviously femur, rectus means what? Up and down, we call that straight, like rectus abdominis, and it's up and down. So, actually slide off the edge, if you would, please. And pull your shirts up just a little bit. Okay, bring your leg up a little bit. I'm going to push down, don't let me. And maybe move that hand out of the way so we can see. So there's vastus medialis, right? All of this is vastus lateralis. It's 3 times as big, if not more, than this. And then rectus femoris is right here in the center. Runs from AIIS down to the superior border of the patella. I don't have vastus intermedius on the list for what reason? It's underneath the first 3. So then slide back again, please. Next is tibialis anterior. So dorsiflex your foot up. That muscle that pops out just lateral to the shaft of the tibia is the muscle belly, tibialis anterior. Get the knee card, you have to palpate the muscle belly. Get the ankle card, you have to palpate the tendon, right? On the way down to the medial cuneiform. Then you got to flip over, please. So one thing you have to remember now, which is the injured leg on exam? Right. I think more than one person has forgotten to walk around. I've done it, right? So I always take, when I'm examining somebody for the first time, I kind of say right leg, right leg, right leg, right leg, kind of get it ingrained in my brain. If you're going to have surgery on your leg, and pre-op, what do they do? Yeah. So my son, they mark the leg that's going to be operated on. They all do that. That tells you what? Somebody at one point operated on the wrong leg. Okay, so the hamstring muscles all have their common origin on the ischial tuberosity, that bone you're sitting on in your butt, right? From there, the medial 2 muscles come down, semitendinosus and membranosus on the medial side. So if he bends his leg up a little bit, that one that feels like you can feel that nice tendon, you can track it up, still have it right there. Begin to lose it. Still feel like I got it.
Yeah.
So from there to there, from there to there, that's why God's name semi-half. Membranosus, you don't have to differentiate between the 2, but it's easy to do. Just say the medial semitendinosus, semimembranosus. Laterally, biceps femoris, which comes down and attaches to the head of the fibula. Bi obviously means 2, long head and short head. Long head, ischial tuberosity. Short head, the back of the femur, which is called the linea aspera. Your anterior femur is convex, but in the back it comes to a point, and that ridge down the back is called the linea aspera. It combines with the long head to form a common tendon that goes to the fibular head. Then the last thing is the gastrocnemius. Gastroc has a lateral head and a medial head. For our purposes, you can just say gastrocnemius. But those are the structures that form the popliteal fossa, which is shaped like what? Geometric shape? A diamond. Superior medial border, semitendinosus, semimembranosus, superior lateral, biceps femoris. Inferior medial, medial gastroc, inferior lateral is lateral gastrocnemius. What's so important about the popliteal fossa is where are all the major arteries, veins, and nerves going through the lower leg. And in the front, thank goodness, right? Sometimes if you fall on your knee, they're not medial, they're not lateral, so there's only one other place, back of the knee. All those structures that you're going to learn about and need to know. So that's the popliteal fossa. Very important. What's in it? Okay, now we'll do ligaments. So 4 ligaments. The first one, I'll go over since he's lying on prone, is the oblique popliteal ligament. So again, if you look at the name of whatever you're talking about, it tells you a lot of information. So we know it's a ligament, obviously. We know it's in the back of the knee, because it's called popliteal. You now know the popliteal fossa. And the fibers run obliquely, where MCL, LCL run vertical. But the oblique popliteal fibers start on the posterior medial aspect of the tibia and come up and attach to the posterior lateral aspect of the femur above. So they run like that. So when you take a cadaver anatomy course, you get rid of all that soft tissue and you see the capsule, you're going to see that. Fibers running obliquely. And now you can flip over, please. So MCL is a broad, flat ligament, has the superficial and deep fibers. Superficial fibers, as you already now know, attach to the medial condyle of the femur, distally, medial condyle of the tibia. The deep fibers, which you'll learn, called meniscotibial, meniscofemoral, attach to the medial meniscus. So that's why when you have an MCL sprain, you might also have a medial meniscus injury. Might, doesn't mean you automatically, but there's a high incidence of that. So it runs right through here, MCL. LCL, lateral collateral ligament, is a broad, is a cord-like ligament, like your little finger or a pencil. So you got to slide off the edge again, and I want you to cross your right leg up over your left leg, so left leg. Okay, then you stick your finger into the joint line, you go back, and he's got a good one. Right, feel that cord? On front of it, on top of it, behind it. And then if you feel, that's your biceps femoris coming into the back. So when you palpate your model friend, if they don't have a good LCL, come over and palpate his. So let's go back one last time. Patellar ligament again runs from, bend your knee up a little bit, tibial tuberosity, inferior pole of the patella. That's the patellar ligament. In Gray's Anatomy, it's called ligamentum patellae, but most people call it patellar ligament. And just as many people call that the patellar tendon. That's incorrect, because it's not a tendon, because it's running from bone to bone. It's the definition of a ligament. The muscle ends up here, right? The quad muscles. So when somebody says patellar tendon, I just say, oh well, never taught them anatomy, just didn't tell them the right thing, right? So that's the ligaments. That's, well, I'm going to show you a film later in the semester about an ACL reconstruction where they take the patellar ligament as the autograft. So autograft means tissue from your own body. Allograft means tissue for reconstruction from a cadaver. So why this was ligament of choice, graft of choice, I'm better way of saying it, they would take a little bit of bone from the tibial tuberosity, the central 1/3 of the patellar ligament, and a little bit of bone from the inferior pole of the patella. So you had bone, ligament, bone. And then when they drill the tunnels through the tibia and the femur, putting a bone plug into a bone tunnel, bone heals into bone better, more quickly than soft tissue into a bone plug. But nowadays with the fixation that they have of the grafts, hasn't become, is not an issue any longer. The disadvantage of taking that tissue is it screws up the extensor mechanism. It takes a while for that to heal, and it throws off your patellar alignment, tracking, and there's always a possibility that it could rupture. So the most famous wide receiver of all time tore his ACL. And who's that? Terry Rice. Tore his ACL. They reconstructed his knee with his patellar ligament, and unfortunately, it ruptured. So they repaired it and went on to continue his fantastic career. But that's one disadvantage. My son prefers the hamstrings, semitendinosus universalis. They stick this wire up your leg, snip it, pull it out, and then turns it over to the PA, his assistant, and they braid it together, double loop it, and research shows it's 4 times as strong as the original ACL. very little decrease in hamstring weakness. Okay, that's all the time.